I come from the Kansas City area. I live in a place called Shawnee Mission. It's not really an Indian reservation. So this is my backyard. I don't have any conflicts or disclosures except possibly some bias against being afraid to treat common duct pathology surgically. So that's where I live. Some of you may remember the Wizard of Oz movie where the wizard told Dorothy to follow the yellow brick road. Well, for biliary tract surgeons, this is sometimes what it looks like, with a lot of stones here and taking those stones out. Some of you may also be familiar with the Duct Dynasty series that's on TV in America nowadays. This is Jace, one of the people on the show, who says that basically you can fix pretty much anything with duct tape and extension cords except bile duct stones. A little bit about the history. I just want to kind of set the stage for why we're having this discussion, and some about the history of what got us here. We look at these three here. IOC was introduced by Maritzi in 1931. The first laparoscopic IOC wasn't done in the 90s. It was done in it was actually 1952 by Maritzi, and this is him presenting his paper, and this is what the paper looked like back in 1931 in Argentina. The first laparoscopic cholangiography was performed also in Buenos Aires in 1952 by Royer. And then in Europe, I had the opportunity to meet this man, André Colomet, in '92 at the first Swiss Congress. He produced a paper, and you can tell this is laparoscopic cholangiography in 1954. And most of us, some of us in the room weren't even born at that time, and some of us were quite young at that time. You can see his nice cholangiogram and the sticks in there. And then we skip forward another 30 years to Mua, this is his galloscope, where he performed the first laparoscopic cholecystectomy. It looked a lot different than what we do nowadays. So what happened between 90 and where we are today? We were, in the old days, some of us older surgeons remember being expected to clear the duct 90% of the time when we did a gallbladder operation. After 94, and actually after 90, we found a lot of reasons not to explore the duct because of a variety of problems. I was fortunate to meet Dr. Magnuson from Johns Hopkins at an SSAT meeting a few years ago, and he got this slide, he shared it with me. It's from Tom Helling's article in 2008 that showed that the average graduating chief resident had less than one laparoscopic or open common duct after 5 years. So that's not good. So what happened after the early 90s was surgeons said, gosh, you know, let's just do something that's easy and fast and let's get out of there. Again, Jace says do it best. If you don't know what you're doing, do it fast and quickly. So a lot of people stopped looking for common duct stones and said, well, we just don't see them anymore. But all of us know that at least 10% of people have that. And then a lot of excuses for not clearing the common duct just seemed to proliferate after that. These posters are from a website called despair.com. A number of people don't think it's a good idea to not look for common duct stones. Bill Traverso and his group in Seattle at the time looked at a number of patient records between 90 and 92, and their conclusion after looking at all the preoperative indicators is that there were no predictive tests that could assure you that the common duct was normal and without any stones. In '94, Parasot, with the Endoscopic Association in Europe, they published this article that said we must move toward a management policy which prevents us from needing a second dangerous and debilitating operation. And by that, they meant ERCP or another common duct exploration. But common duct exploration was thought to be too difficult. If you can't read this in the back, it says if you expect to score points by whining, join a European soccer team. Nothing against the people in Europe, it's just a joke. So, and then another demotivational picture. If a pretty poster and a cute saying are all it takes to motivate you, you probably have a very easy job, the kind that endoscopists or radiology interventionists will be doing soon, yes, even gallbladders. So Again, from another, in George Bursey's book, the laparoscopic IOC and common duct exploration is shown to be the most efficient and cost-effective way of treating common bile duct pathology. In the early 1990s, a number of people who are going to be speaking today were asked to present about laparoscopic cholangiography at an NIH conference. Eddie Phillips, Marty Aregi, and a few others, and myself. And then in 2002, there was a conference on ERCP. I was fortunate to be invited to speak at that. The conclusion from that was that common bile duct exploration and post-op ERCP were both safe and reliable in clearing common duct stones, but there is a need to enhance and evaluate training for laparoscopic common bile duct exploration. So that was in 2002. Again, we have Helling's data that shows we're not doing that during the residency time. So that's one of the reasons we have this today. If you pursue this path and don't even look for common duct stones, it's going to cost more. We prefer that you go this direction. So with that in mind, I'd like to turn the podium over to Dr. Duncan, who will introduce our first speaker. Thank you.